Hi, everyone. Welcome to LDI's virtual seminar for today, which is Recessions and Health in the Time of COVID-19. I am Rachel Warner, LDI's Executive Director. The COVID pandemic is having a profound effect on health, as we all know, with last week coronavirus passing heart disease as a leading cause of death in the United States. But the effects of COVID go well beyond the immediate health effects of the infection. It also has a crippling effect on the U.S. economy. Unemployment reached new highs this week with 22 million jobs lost in the last 4 weeks. And we face significant uncertainty about how much higher unemployment will go, how long it will take the job market to recover, and what the effects on poverty will be. The downturn in the economy has raised many understandable concerns about joblessness and poverty, but it also raises concerns about what the long-term health consequences of a deep recession might be. Here to talk with us today about this is Athene Venkatramani. Athene is a physician and an economist here at Penn, and he's an assistant professor in Penn's Department of Medical Ethics and Health Policy. He's also a senior fellow here at the Leonard Davis Institute. His research focuses in part on the relationship between economic opportunity and health behaviors and outcomes, and we are thrilled to have him with us today to talk about the economic fallout of coronavirus, recessions, and health. Athene, I will turn it over to you.
Great, thank you so much, Rachel. I'm going to talk a little bit about what the data tell us we might expect from the spillover effects of the COVID pandemic on the economy, and in turn on what that might mean for population health. Rachel already set this up, but you may all have seen a version of a graph like this, but this is basically the number of initial unemployment claims over time. And if you look at the far right of the graph, as Rachel mentioned, there's been this unprecedented spike in initial claims. 22 million people, that's 1 out of every 6 workers in the economy, have filed for an unemployment claim, and that spike makes the Great Recession look just like a very small blip in an otherwise stable time series. So Geeta Gopinath, the chair of the chief of the IMF, called what we're going through right now the Great Lockdown. So let's talk about how the Great Lockdown might affect health. So I'm actually going to start with what we know from lots of data and lots of research on how economic downturns might influence health. And then we'll shift over to talk about COVID. So what can we expect based on historical experience with regards to COVID-driven downturns in health? What do we already know that the COVID-driven downturns may be doing to health? And what might be different about COVID-19 and its associated downturn? And then we'll finish by talking about policy responses, and then I'll take your questions. Okay, so let's go into the literature a bit here. So we're going to start with what might be a surprising finding, and this is from earlier literature, looking at recessions or downturns rather in the 1970s through the early 1990s and its relationship with mortality. And what you see on this graph here is that, at least during that time period, mortality rates actually seemed to decline when unemployment rates were going up, suggesting that there was this counter-cyclical relationship. And you see some of that pattern in the Great Recession just 12 years ago. So one paper found that overall mortality, that's all causes, all people, decreased by nearly 4 deaths per 100,000 for every 1% increase in unemployment rates. And overall, that probably amounts to about a 2 to 3% decline in the mortality rates during the Great Recession across the country. The deaths that were averted potentially by this were cardiovascular mortality, but we also saw lower mortality from motor vehicle accidents, homicides, and legal interventions. It wasn't all a rosy picture, though, because mortality did increase from drug overdose and suicide among working age adults. So there was a mixed pattern, but overall fewer deaths. Why might this be the case? It's a little bit of a surprise. There's been many theories. I think you can see them here. Probably the best evidence is for lower air pollution, which may account for 2/3 of this kind of reverse relationship between economic downturns and mortality. There's mixed evidence for a lot of these other potential mechanisms, including health behaviors, quality of care in nursing homes, and job stress. I do think, though, that if you look at the evidence that has come forward of late, that there's a lot more harm to downturns than we initially realized. So if you look at newer research examining the relationship between unemployment rates and economic downturns in health, it looks like, if anything, there's no relationship between those two factors, or potentially a negative relationship, meaning that higher unemployment is in fact in more recent times, Great Recession notwithstanding, associated with higher mortality. If you look at measures of morbidity, you definitely see evidence of harm. So there's been a lot of work that's linked downturns to poor mental health. Researchers who have looked at physiological markers like blood pressure or blood glucose find that these worsen during the Great Recession as well, but during other downturns too. And other health conditions, such as those from intimate partner violence, seem to increase during downturns as well. And the people that are affected are those that are younger, those that tend to have lower levels of education or lower levels of income, and those that are near retirement. As they ponder their next phase of life, recession at that time can hit them pretty hard. We also know that large downturns are harmful too. So this is data looking at 32 countries over 100 years, and all the different recessions averaging over all of these. And if you look on the left-hand side of this graph, really, really large downturns, that's what you see on the x-axis on the left-hand side, are associated with higher than predicted during usual time mortality rates. That's what you see on the y-axis. And moderately sized recessions don't seem to have any impact one way or the other. Maybe there's a little bit lower mortality during those times. We also know that downturns that are persistent can be harmful too. So there's a famous paper in the Quarterly Journal of Economics by Sullivan and von Wachter that looked at steel plants in Pennsylvania and showed that after layoffs in these plants, in these towns that were really dependent on these plants, you saw excess mortality from the year after that. This is actually one of our papers that looks at what happened to drug overdose mortality after automotive plant closures relative to places that didn't have a closure, and you actually see a pretty large increase in drug overdose deaths in a few years after these plants closed. Not only are these types of downturns harmful for workers, but they're also harmful for would-be workers. So this graph is a paper from Hans Schwant and Till von Wachter, which was in the NBR series this year. And this looks at what happens to people who are about to get their first job, who graduate or on the cusp of entering the labor market during a downturn. And for those who are unlucky enough to enter the labor market during bad economic times, you see that by age 40, their risk of mortality relative to their peers who may have graduated during good times is actually already higher. And if you walk it back earlier in the life cycle, so looking at even going down to in utero exposure, so if you look at mothers, for example, pregnant women during recessions, they have much greater stress, especially those who are low income. And the babies that are born during recessions to those mothers tend to have worse birth outcomes. And we know from a long literature in a number of fields that birth outcomes are associated with health and well-being throughout the life course. So taking all that evidence together, what can we expect from the COVID economy, if you allow me to call it that? And here's what I would worry about from these data. I would worry that a persistent, prolonged, and deep downturn from COVID could worsen mental health, could worsen substance use disorder, and could lead to increases in domestic violence. I think some chronic diseases, the data suggests, could worsen. Possibly there's others that may improve, such as those that are sensitive to air pollution. And you would worry about people who are not in the labor force too. So these long-run effects on well-being and health for those who are just exposed much earlier in the life cycle. A challenge with attributing any of these potential health outcomes to the COVID recession is that COVID is doing lots of things to many different dimensions of life. So you could imagine that social isolation, changes in access to healthcare and the way healthcare is delivered now, maybe even being out of school, for example, all of these things could work together to modulate what might be the effects of COVID directly, as well as the economic effects of COVID on health outcomes. We're already seeing COVID, the economic consequences of COVID leading to adverse health consequences. So this is actually a survey that Elizabeth Anand and co-authors had in the field among working families in a large city that happened to be in place when COVID struck. And when you see these, the emergency or restrictions being imposed for people going outside, you see that not only do people work fewer hours in these working families, but you see that an index of mental health, which includes depression, anxiety, and externalizing behaviors among children, also starts to worsen around the same time. So the early data are already showing some harm to health. As far as harms to health going forward, there's a lot we don't know about COVID. So the first thing is, what is the size and and duration of any potential economic downturn going to be? And one of the, I think, things that makes COVID different is a lot of it could be driven by fear and uncertainty. So we don't actually know what people are thinking about their own risk as they go and navigate the outside world. We know from some new data that even before social or isolation type policies were put into place, people were already interacting with the economy less. They were less likely to go outside, less likely to get restaurant reservations. They were already social distancing. So how long will people feel that they're at risk could determine, and how uncertain they are about what the world will look like for them could determine both the depth of the recession that may follow and its duration. We also don't know what will happen to the supply side. So if people are out of work for long periods of time, what will happen to the goods they produce that we rely on to live our daily lives? That may also have some impacts on how deep this recession will. The graph on the right here is from, I think, what is an interesting model that uses other black swan events, such as terrorist attacks and natural disasters, and quantifies the role of both uncertainty and some of the direct effects you might expect from an economic downturn on the potential size of a downturn that we could expect from COVID. And just from uncertainty alone, which is this red line, this model predicts a recession or a drop in GDP growth, which is pretty similar to what we saw during the Great Recession. And then everything else on top of that would double its impact. So this is obviously a dire prediction. We don't know what's going to happen, but it does show you really the importance of what uncertainty in this COVID world could do as far as the depth of what we might face. So what are some policy responses that we might consider during this early time? Again, realizing that we just don't know a lot about what's going to happen, but we do have some evidence to guide us of what could happen. So there's been a lot of talk about what I would call a trade-off between the economy and health. And the story usually goes something like this, like by implementing distancing interventions, we're putting people at risk for poor health outcomes that is as bad or as worse as what COVID might do directly. And I hesitate to really operate on the trade-off for a couple reasons. One is there are estimates of trade-offs between these types of isolation policies and infectious disease. Jerome Otta and co-authors have a great paper in the Quarterly Journal of Economics on this. And for diseases that are not that severe, it is not cost-effective to engage in these types of isolation policies. I think we all sort of intuitively believe that. For diseases that are more severe, though, I think you would find that a lot of these interventions could be cost-effective. So that's one reason why maybe robust public health intervention should come first. Another thing I would say goes back to a point I made earlier, which is that people have already been distancing even before we put in policies to tell them to not go outside. And a lot of that gets to the fact that it may not even be these isolation policies that are driving what's happening in the economy. It may be people's own fears about the disease that they could catch. And so there again, I think there's a role for public health intervention. If you go back to history, and this is a graph from a paper looking at the 1918 flu pandemic, what this graph shows is the mortality from the flu pandemic, and that's on the x-axis, and on the y-axis you have the change in employment. And where you want to be on this graph is in this top left corner, where you have better employment over this period and lower mortality. And what you see is that most of the cities that are up in that quadrant tend to have these green dots, and this green dot denotes cities that actually implemented stricter public health measures. So there's some historical evidence that public health interventions are a way out of this kind of conundrum of trading off the economy and health, and can make that trade-off actually not a trade-off at all. Not a huge trade-off, rather. What will that take here? I think experts seem to think that increased testing and tracing capacity is going to be important for us to be able to safely reopen the economy. We need an understanding of the immunity. How long does that persist among people who do have COVID? Vaccines obviously would help if those are potentially deployable and have, I think, relatively good duration. And just understanding what distancing policies work, what distancing policies maybe are less necessary, can help us in a piecemeal way reopen the economy safely. While we're doing all this, I think good economic policy is going to matter a lot. And one of the interesting things about this downturn relative to others is that the government's problem is really to get people to stay home, at least in the short term. And you want to support people or pay people while they do so. And so different policy responses in industrialized countries have included increasing the duration of unemployment insurance, having some sort of paid sick leave system, direct cash transfers to people, paying companies to pay employees, like some of the European countries have done. Some countries in Europe have job guarantee programs, and then generally expanding or improving access to the social safety net. And our approach so far has been we have made unemployment a little more generous. We have extended the duration by 13 weeks from 26 to 39. We have a sick leave system in place for many workers. It's maybe not as extensive as European countries, but that was a move that was in our recent stimulus. And there was a cash transfer, or is an ongoing cash transfer of a one-time check of $1,200 to people who make generally below $75,000. So this is kind of the scope of what we could do. This is what we have done. And early evidence suggests that we probably are going to need to do a little more than what we're doing now. This goes back to the paper by Elizabeth and Anna and co-authors, where they're looking at what happened to people's income in a survey in this large city among working class families. And among those who had paid sick leave or some pay for lost hours, you see that the income declines. Many more people experience steady income, and fewer people experience large declines in income relative to not getting any support. Of course, we can't say that this is a causal story. Those types of jobs might be different. And moreover, even with the support, we do see those people in those companies that are supportive having some income decline themselves. But it does suggest that protection can potentially work. More evidence on this would be useful. I think there's a whole history of research on the social safety net that we can bring to bear for our current problem. And it's not just about really the generosity of the safety net, it's also about improving access. So this is something I calculated. Here on the x-axis, we have the Great Recession, and this is the size of the Great Recession shock in different counties, and this is the largest shock out here towards the right. And this is the effects on what we call deaths of despair, so drug overdose and suicides. And what you see is that in some parts of the country, you had, for large shocks during the Great Recession, you had an increase in drug overdose and suicide deaths. And in other counties, you didn't actually see that change at all. And the difference between these two actually is the number of hoops you have to jump through to get access to the safety net. So it's not even the generosity of the safety net per se. It's just how many things do you have to do to access those benefits, suggesting that making benefits accessible, especially during a time like this, might be good for people and may avoid some of the health harms that we have typically seen with downturns. And not only is it about improving access to getting the safety net, but we also have to think about how good the plumbing is. A lot of our systems for dispersing funds through the unemployment insurance system, for example, through SNAP, through TANF, are really old. And during the Great Recession, we had actually, the federal stimulus, as part of that, had some money set aside for states to modernize these systems. Some states did, some states didn't. But what you're hearing now is with 22 million unemployment claims in a 4-week period, you're hearing states becoming overwhelmed and unable to actually process those claims. And so in an era where we're witnessing unprecedented economic distress in such a short time, the plumbing has to be good to deliver benefits, in addition to the benefits themselves potentially being more accessible and potentially more generous. So I'm going to close with what I think is the big picture. So we're in a population health crisis, and I think everyone recognizes that now. But we've been in a population health crisis for at least 40 years. And what this picture shows is we're taking U.S. counties, and we're dividing them into different deciles of the average levels of education in those counties. And we go from 1970 over to 2020, and on the y-axis, we're plotting the mortality rate for working age adults. If you're in the counties that were always in the top decile of education, which also tended to have the highest per capita incomes, you see a secular decline in mortality, right? Maybe leveling off after 2010. If you're living in that bottom decile county, mortality rates actually started increasing in 2000. And at current levels is actually higher than where it was in 1980. And similarly, those in the middle have been left behind too. So the economy has become increasingly more and more important for people's health. The people that have not been winning in the economy since the 1980s have also been losing in terms of their health outcome. We've seen this over and over in a number of different ways. whether it's, we call it the deaths of despair, or whether we look at even other causes of death like cardiovascular mortality. COVID is only going to make this worse. And I think that the policy steps that we take now could potentially be helpful. We might want to keep some of those things because we've actually been doing poorly in population health outcomes for low-income folks for a long time. So I think I'll close there and take your questions.
Thank you, Athene. That was such a great presentation. And I wanted to talk a little bit more about ways in which this potential economic crisis from COVID-19 might be similar or different from other ones that we've seen in the past. This is certainly the first one we've seen, which is caused by a collapse in the consumer services sector, whereas most, like the Great Recession and recessions prior to that, were caused by collapse in the investment market and investment spending. I wonder if you could talk a little bit about how this recession might differ and what the implications are for health in that way.
There's uncertainty in every recession about when things are going to change, but I think the extent to which people themselves are afraid to interact with the world in a way that is safe for them may drive a lot of economic activity. So that's the consumer demand side that you mentioned. But there's also this double-edged, well, it's not a double-edged sword. There's also the other side of it, which is the supply side, which I think could suffer in this economy too. The people that are producing essential services, over time, if they're not going to work, we are going to see some diminishing delivery of goods and services through supply chains. And I think that would be a double hit. And you already see this on the business side. So that graph I showed about uncertainty and what we might expect for the size of the downturn actually uses data from surveys of businesses, which track whether businesses are going to invest or are they going to save their money in this downturn. And it turns out that businesses have no idea what's going to happen. And as a result, the uncertainty that they're facing is so large that they've actually clamped down some of their own activities. But I think those are two really big pieces. And then that's to say nothing about things like the speed of this. It happened really quickly. The potential size of it, which could be enormous for, I think, pretty much anyone who's on this call our lifetime. And I think just this there's a number of other things that I think are more speculative, but this is in some ways a product of being connected with the world. And so in the long run, how will we rethink those kinds of connections, if at all, is another important question. So in the short run, I think speed, size, duration, the role of consumer demand and fear are probably the biggest things that are going to be different. And in the long run, it's anybody's guess.
You pointed out some of the major differences in such a nice, concise way, but I wonder if you could talk a little bit about how those unique factors about this particular economic downturn we're having might think about how we might, from a federal policy standpoint or from a societal standpoint, think about addressing the economic downturn and how we think about coming out of this.
So I think the first thing is going to be on the federal policy side is really a large amount of investment in the public health piece of it. So if it's true that economic activity was starting to cease even before we told people to stop, it means that when we restart things, this kind of, we always hope that there's pent-up demand that'll lead us to have this kind of economy that's booming again very quickly, but it may not be the case if people are unclear about their own risk. So I think the biggest piece is, again, the public health investments. There are estimates out there that we're probably investing by a factor of 3 in terms of things like testing capacity, tracing, all the raw materials and personnel that go into making that work. That's probably a fair underestimate. If you think about the greatest recession stimulus, in retrospect, I think a lot of people believe it should have been twice as large as it was. We just didn't know at the time. So that would be piece one. And I think piece two is we do have to rethink how we're delivering benefits to people in need so that we can keep things afloat. So again, some of it is a problem of scale. So we had as part of the stimulus, there was a program that tried to keep small businesses afloat that businesses could apply to get these loans to keep things going. And as of yesterday, that has run out of money. So there's another program that probably should be larger. As far as consumers and people and families, delivering benefits through the systems that we've been using may not be the right approach in something as large and fast as this particular crisis. If it's true that the plumbing is not very good in getting money to people, then maybe the policy should be reimagined. So that might be an argument, and at least one Republican senator has even proposed this, to just pay people 80% of their paycheck or 90% of their paycheck indefinitely until we're done with all this, or pay businesses to pay people rather.
Okay, I'm going to ask one more question. We're getting a lot of questions from the audience, but I'm going to take my prerogative as moderator to ask you one more question before I turn to them, which is, I wanted to talk a little bit more about the health effects of COVID-19. So there's obviously immediate and profound health effects with the mounting number of deaths. And Athene and I were talking before the seminar about what's going on in hospitals and severity of illness and really like the tragedy we're seeing in the immediate term on health. And then you've also outlined the longer term effects on health that we're going to start seeing as this economic downturn progresses. Could you just talk a little bit about how you would sort of compare the potential health effects of the economic downturn compared to those immediate effects, and how much of in the long term are we going to see more? It's hard to quantify, and the future is certainly uncertain, but how you would think about the size of those health effects compared to what we're seeing right now in the very short term?
It's really hard to tell. I think that the potential spillover effects through these downturns or whatever it might be are quite large, both in the short term and in the long term. I think this is a shock that we'll see reverberate for years in many ways. So working age people right now, especially those in the lower end of the income distribution, I think will experience worsening morbidity and potentially mortality as well. The children growing up in those households as a result of economic insecurity may suffer in the long term as well. I mean, there's a ton of good evidence around children in particular during challenging times, how that persists later into life. So I think this is a multi-generational shock. The reason for protection in some sense is not just to save people now, but it's to kind of prevent that ripple effect from reverberating forward. As to the relative magnitude, it's anybody's guess, but I think that the indirect consequences of COVID could be incredibly large, maybe even larger than the direct consequences. And that's not saying that we shouldn't be doing what we're doing in terms of social isolation or these public health approaches. What it's saying is that the public health approaches really matter, because you want people to be confident and engaging with the economy and safe, so that when we do open things up, we can do so in an expeditious way. Rachel, I'll also say that for people who are doing research on this in the future, this is the way I think, I'm a researcher too. It's going to be very hard to disentangle the direct and indirect effects. And then how much of it is the economy versus isolation versus the changing way that we engage with the healthcare system. So there's anecdotal reports of people being afraid to go to the ER for something they otherwise normally would. Trying to disentangle all those different pieces is going to be very, very complicated. But I think we have a lot of evidence to guide us.
So one of the questions from the audience is about how to deal with the economic fallout of the COVID pandemic, and it is, what are your thoughts about work reassignments? This will help both the economy and public health. For example, the long-term care workforce was low prior to COVID. Now nursing homes can't even get employees with increased pay enticements, yet they're all in need of staffing. And it's complicated because of what's going on in nursing homes related to COVID, but in general, what are your thoughts about work reassignments to try and address this?
There's been a number of interesting things put out there. One is that if we're going to go the test and trace route, tracing requires lots of personnel. And so it's possible that we can temporarily hire lots of people and train them to go and do the contact tracing, or to even do the testing. And that'll require, I think, a concerted approach to train people to do it properly and all this. But I think that these are innovative approaches that we should be talking about. Especially where there's need. I think there could be a captive labor force that is interested in doing the work. You'd want to make sure that it's compensated well, given that there's risks to doing that. You'd want to make sure that people are safe and that there's enough PPE and things so that it's a job that's palatable for people to do and doesn't just capture a group of people that may be facing a very sad trade-off between their health and their income. But I think that's a really interesting approach. Also, an interesting approach is to just, again, pay people to continue to do their jobs, but basically paying them to stay home from their job, so that when they're done, they'll have a job when they return. So I think combinations of all these things will be important. And we're so early in this still, but I think now is really the time to start being creative because we're having these conversations about when to open up. And I think that's an interesting idea.
So we've got a couple questions about Medicaid, and you had mentioned the role of the safety net in the healthcare safety net in trying to address the health consequences of recessions. I wonder if you might just talk a little bit about what the role of Medicaid, how Medicaid might be impacted by a recession, and then what the role of the safety net is in trying to help overcome the health consequences of it, particularly related to your earlier point that we need to really improve access to the safety net.
I think the Medicaid program is incredibly important. Let's start with the Medicaid program. So there was an interesting brief in the Kaiser Family Foundation just in the last few days about what happens when people lose employer-sponsored insurance in different states. And it's a complex calculus of whether you're in a Medicaid expansion state or not, whether you are, like, what your baseline income was before you became unemployed and how much would unemployment insurance add to that. And based on that, there's like 6 different scenarios about whether one would get, what type of coverage one would get, whether that would be in the Medicaid arena or would that be in the marketplace. The first comment I have is that that article was incredibly well written, as all Kaiser articles are, but I had no idea what was going on. And I think that's actually the problem. You have a benefit structure that during a crisis time depends on many different interlocking factors that requires lots of decision making and cognitive work for people to do. And it's hard to navigate. So the first thing is, I think you want any benefit to be easier to navigate. Number one. With Medicaid in particular, I think it could play an important role here in 2 ways. One is that obviously for people who may lose their job or who have qualifying incomes, this is going to actually help bolster their health outcomes, bolster their access to health care, potentially prevent financial ruin, and maybe, for people with chronic disease, help with their needed medications and so forth, and kind of weather the storm for people. That's number one. Number two is for Medicaid expansion states, a lot of the expansion population are really benefiting from what is effectively 90% extra, 90% FMAP for that expansion population. So this is a big bolus of cash that's coming into expansion states during this downturn, where we almost inevitably are going to see more people get the Medicaid program. So it's one way for the feds to transfer money to states that I think will be useful, especially because we worry that state budgets are going to be challenged. On that point, one of my colleagues, Rourke O'Brien, who's a sociologist at Yale, on Twitter put out an interesting idea, which is why not just federalize the program temporarily, meaning no state contributions. That's a direct transfer to states, and it'll allow states to spend their money on other things. For example, maybe their bureaucratic infrastructure to deliver other benefits like SNAP and TANF, which I think, that's the welfare program, which I think will be equally important in helping people weather the storm. So simplicity of the safety net, more generosity, allowing states more flexibility, or allowing states to prevent a budgetary collapse so that they can fulfill these basic functions. I think all of those things are going to be key. And the Medicaid program, at least from the federal side, could be one nice lever for the government to use.
There was a question about what the role of rurality is in the pandemic and whether or not there's historical evidence of different responses in urban versus rural settings with respect to mental and physical health, both during a pandemic, which we don't have a lot of experience with, but also during recessions, which we have more experience with.
So thinking about the economic effects first, rural areas, I think there may be towns where there's 1 or 2 industries. So Lizzie Bear, who is one of my colleagues who's on the call, was telling me about a pork processing plant in Sioux Falls just about an hour or 2 ago, where almost all the workers or many workers have gotten sick. And if the plant closes, that's actually a huge economic shock to this like one town. So to the extent that rural areas depend on a single sector for employment and that sector is hurt, you could actually see the economic pain being much, much worse. And that may be worsened by the fact that the hospital infrastructure in rural areas is less developed than in urban areas. So people may not have the same access to care in those places than others. So I think those are 2 ways that'll be different. As far as the dynamics of the pandemic, I think this is anyone's guess. So in urban areas, you may assume that population density is one thing that will help the virus propagate itself in tightly knit and close together communities, whereas in rural areas, maybe the distance between people will prevent that. I'm not sure what the data have shown on that, but I think that there would be reasons to be concerned about rurality. The lack of healthcare there, maybe the dependence on a single industry, the general isolation, maybe there may be more sensitivity to supply chain shocks. So I think these are things I would worry about moving forward.
So you mentioned in areas like where an auto plant closes or things like that, and your own prior research has looked at increased rates of deaths of despair, so deaths that are due to suicide, drugs, and alcohol, which has been a big concern over the past decade, which is a general rise in deaths of despair. I wondered if you could talk a little bit about how you think the pandemic might affect deaths of despair, particularly because not only is there going to be an economic downturn, which we know is linked to these kinds of deaths, but it also comes along with the social isolation and mental health impacts that we've seen from the pandemic.
I think in the Great Recession, despite, I think, the increased availability of opioids then and this kind of force of trajectory of deaths of despair increasing, even a shock like the Great Recession on top of that seemed to add to deaths of despair. So I think that in many ways, drug overdose and suicide have just been on the rise because of that last graph I showed, which is this for a lot of this, which is that there have been people that have increasingly been falling behind in the economy, and to the extent that COVID worsens that force can also worsen deaths of despair. There's also, on the isolation side, on the healthcare side, I think you would worry that people who are being treated, for example, for substance use disorder, maybe it becomes more difficult in these times to get the necessary treatment to maintain good health for that condition, and maybe that may or may not increase the risk of overdose. I think that's anyone's guess. I've seen arguments that social isolation may actually not have as large impacts on suicide mortality as we might think, because of the fact that the country's coming together and there's actually this kind of shared we're in this shared fight against this virus. But those arguments aside, I think we should be very worried about the population that is at risk for poor mental health, who either already have or are at risk for substance use disorder, given it's going to exacerbate many of the trends that have potentially potentiated this and reduce the access to care that might be needed to stave off, for example, a fatal overdose.
So last week, LDI had a seminar in which we talked about the impact of COVID in particularly vulnerable communities. And I wonder if you could just connect some of the research that you've been talking about to recover, how we might expect the pandemic to affect the economic recovery in particularly vulnerable communities, such as high minority counties or various poor areas, and what the long-term impact for economic growth in those areas might be, and then how we might think about addressing that.
I think if you look at the types of workers that the economic consequences of COVID are expected to squarely land on, they tend to be low-income workers in service industries, in particular. Low-income workers in essential industries, for example, healthcare, or the people that work in the grocery store, are also affected, but not necessarily by the economic consequences, at least initially, but by the fact that they're facing an increased disease risk while also having to work, and they may have to make a hard choice about what to do there, given the resources they have to bear. So I think that we know that there's been incredibly large disparities in health outcomes by race, ethnicity, and level of education and income. I think we can expect in the short and medium run that this will worsen in COVID. And I think Dr. South, Dr. Kengovi, Dr. Culhane did a great job last week kind of illustrating why. As far as the long-term growth potential, it depends on what happens to the industries that employ low-income workers. And it's hard to know. I mean, you could imagine so for example, you could imagine that consumer demand doesn't really rocket up because people are still afraid of the virus when we open things up, so that there may be this lagged effect which could worsen the pain for these workers. So that's one possibility. You may imagine that businesses may start to close over time if there's no support to keep them open, which would also affect these workers would be without jobs, which is a tremendous shock to face. And it may also be that pandemics like this may force some businesses to reimagine how they engage with workers. So I'm thinking of a McDonald's where you can go and like press something on a screen to get your order, and maybe that robot replaces a worker, and maybe this would actually speed up automation, which I think we know has led to declining economic opportunities for middle and low wage workers. So there are a number of long-term effects that I think are unpredictable. Again, it'll depend on the size and duration of this shock, and of course what we do on the public health side to mitigate that, and then what we can do to support businesses as we go through it. In the same way that this will exacerbate disparities, it's possible that if we take good policies now, we can actually ameliorate some of these disparities. So Elaine Hernandez at the Indiana University has done a lot of work on what she calls universal policies, which are basically large-scale policies that are available to everybody but have larger impacts among marginalized populations. And I think this might be a time to consider those things, given that for 40 years or more, many people have been left behind.
So with regards to policies and supporting small businesses who offer employment to many people, there's a question about unemployment insurance. So in some cases, employers lay off employees because the employees will earn more with unemployment insurance than on the company's payroll. And how can we balance these incentives to create a strong unemployment safety net while also giving businesses the protection that they need?
And I think that's another reason to potentially rethink our response. I mean, we are leaning very hard on the unemployment insurance infrastructure. It's possible on the margin that there are perverse incentives like this. But it just goes back to what I was saying earlier, that maybe this is a different situation. We want to just put everything on pause. And in the ideal situation, we press pause for some period of time, support people while we're pausing, and then when we unpause, people go back to their lives. That's pie in the sky, but relying on the unemployment insurance system to do that, I think, faces a number of barriers, whether it's, in this case, perverse incentives, just the sheer bureaucracy and I think the frictions in the pipeline to deliver those benefits. It might be better just to have businesses pay their workers. So this is another argument for thinking about something different. Just to point out, I'm not advocating any policy here. I'm just kind of laying out the landscape, but that would be a pro for a policy like this versus relying on what we're already doing.
Getting back to some of the health effects of the current pandemic, there's a question about the effects of air pollution. So the question is, what are your thoughts on the extent to which reduced air pollution might reduce the health impacts of the current pandemic?
That's a great point. So I think the reduction in air pollution is going to help. So there's, if you want, you can go to NASA's website, or there's a number of these websites that track the environment, and you can look at air pollution maps for like Los Angeles. It's amazing or New Delhi or Beijing, and it's amazing how different these places look now. We know from the historical evidence that when I was talking about potentially what in historical times could have been this opposite relationship between business cycles and health, that 2/3 of that opposite relationship was driven by just less air pollution. So we know that reducing air pollution in these times is one of the pathways by which people can be healthier during recessions. And I think the fact that none of us are really doing anything, and probably pollution levels in many of these cities are at historically low levels, at least in the recent history, suggests that there could be some attendant health benefits from that. It's going to be really hard to pick those up. I think it'll be probably once death certificate data and hospitalization data are kind of vetted, cleaned, and come to our attention. I think a smart demographer or economist is going to be able to tease these. You might look at asthma admissions in kids, for example, and see that there's fewer of those. I think it definitely will help. And it's just, if we learn something from this, maybe it's that we should have less air pollution all the time. But yeah, I think it'll help. To the extent that it'll offset all these negative things, I'm not sure. But it's an open question.
How about the extent to which there will be non-COVID deaths? So you've touched on this a little bit, and I know this is something you thought a little bit about, but there's been many reports of hospitals seeing really very low numbers of patients showing up with heart attack, stroke, heart failure, things that we used to see routinely in the emergency room that aren't there now. What are your expectations in terms of the impact on non-pandemic health that are going to come out of this?
Yeah, independent of any recession, I think I would be worried that we would see some increases in non-pandemic deaths. There's been some data looking at the trends in deaths at home relative to historical trends in different cities like New York. And there seems to be a pretty large spike relative to historical trends of people dying at home. Whether that's from COVID or from something else is not clear, and I think the death certificate data will ultimately help us get there. But it is concerning to see, I think, notable spikes like that, even in early data. And the caveat is death registrations. If you're looking at deaths that happened a week ago, that data is probably incredibly incomplete. But it is concerning to see that there's more and more people dying at home, and it makes you wonder about these potential rise in non-COVID deaths.
One of the things that you said during your presentation was that the expectation of this economic downturn is that it's going to last our lifetimes. And I wonder if what you worry most about in terms of how that's going to impact the people who are young right now, like our kids. What do you worry about in terms of what the health consequences and the economic consequences of this kind of recession is, which could be as big as the Great Depression was?
When I said that the economic consequence of this downturn would last through our lifetime, I actually meant that it would be even if the economy recovers in the GDP growth sense, the reverberations of this crisis could be seen in children, right? And the people who grew up during it. So that is everyone who entered the labor market during a time where maybe jobs start to become scarce, all the way down to children who were born during this time and were in utero during a period of significant maternal stress, for example. In that sense, you might see the imprint in those cohorts. And I think that that's always a very sad result of these types of shocks, right? Whether it's to the economy, to the environment, political shocks. And I think it really just should make us think about how to double down with good early interventions. Not just medical care, but making sure that preschools are available to people, especially low-income kids. Trying to reduce the digital gap, at least in the short term. So if we're homeschooling people, can everyone actually access the content that they need? And for people who are graduating into the labor market, Catherine McLean at Temple was speaking at BU about the economy and health yesterday, and she made a great point about thinking through how to reduce the debt of folks that are kind of getting into the economy during bad times, finding new ways to engage them, maybe allowing them to have more mobility across the country so they may not be able to afford to move to a place where the economy might still be booming, but maybe we can help people make that move so that they can still access jobs and not suffer this lifelong consequence of just being unlucky. I think it draws down, I think, on everything we've thought about early childhood schooling and early labor market entry for many years. All of that research that people like Janet Curry, Raj Chetty, others have done, Nancy Adler, I think all of that applies to this situation, and we should try to enact it.
So in thinking more about the health over the short term of the population, if you could wave your magic wand and decide how we were going to measure the health of people sort of over the course of the pandemic, which likely will last months, if not over a year, how would you think about measuring population health, or what metrics would be useful to guide how well we're doing in response to pandemic over the next couple of years?
I think in real time, good survey data would be incredibly helpful here. So I think there's a lot. Self-reported health status, while it has some biases, I think is pretty predictive of a lot of long-term objective health outcomes. So I think that's a cheap thing that we can track in large-scale surveys, and these are questions that can be asked every week. And in fact, there are people who are doing these surveys now I mentioned Elizabeth Ennon as one of them, but there are surveys in the field to kind of do this. So that type of real-time tracking will be important. You'll also want to know how people are accessing the healthcare system. You'll want to know things like, I didn't go to the pharmacy today, or I couldn't get my refill, or I've run out of insurance, or I don't have insurance coverage anymore. I think I have this level of medical debt. I think these are all things that people have historically asked in health surveys. The BRFSS is an ongoing survey, right, that can potentially use that infrastructure. But yeah, tracking that in real time will be helpful. And there may be subpopulations that you want to survey with chronic diseases that health systems could do to basically check in and say, as part of their surveillance, just check in and say, how are things going with you? So for a heart failure patient, like, did you gain a lot of weight in the last 2 days? That type of thing. But I think good, large surveys that are real time in the field will be incredibly informative. Anything else right now that we're doing, I mean, in the talk that I gave, there's a fair amount of guesswork, right? And I tried to be honest about where that is. But I think we have the infrastructure to get objective data. And if we're getting objective data about people's COVID symptoms, we can also ask them about their other health conditions. That's as easy to do, and that would be where I'd start.
Okay, we're coming up at the top of the hour, so I wanted to end with one more question about how we might best respond to this COVID pandemic. So if you could think about the federal policy we've had to date and what we've done to try and address it, what do you think we're missing, and what should we really be doing to minimize the impact of the pandemic and of economic downturn on health? How can we really make the future a brighter place?
So I think first thing would be really ramping up investments in the public health side. So this is testing infrastructure, all the materials that go into that, tracing, everything we're doing to understand immunity and vaccines. I think there just has to be a lot more money going into that. That's the first thing, because that's going to, if we're making a choice between the economy and the health, I would say we don't have to if we do the health part right. That's number one. While we're waiting this out, I think we have to at least triple the amount of support we're giving to small businesses. We want them to stay afloat so people have jobs. I think maybe rethinking how we're dealing with unemployment insurance. So are we going to wait for people to become unemployed and then hand them a check that may or may not cover their expenses, versus should we just ex ante, like, tell businesses stay open? We will pay like some large fraction of people's wages so that we can just kind of ride this through. I think we should move maybe towards a system like that. I think removing administrative barriers in social safety net programs. So there's a lot of vetting that goes into people who apply to these things. Just make the applications easier. Maybe do the vetting afterwards. Maybe, if people have to go through 10 steps to get SNAP, maybe reduce that. Maybe take the work requirements from SNAP out, just nationwide, like we did during the Great Recession. I think these are all easy steps that can be taken in the short run. Consider federalizing Medicaid. I think that's a good idea. And then just really invest in the plumbing. Make sure that we have good systems to disperse need and aid to people when they need it the most. And I think that would be more of preparing for the next thing that'll happen. And then when it's all done, consider keeping some of these things in place. Because we've had a long, hard road in terms of population health for 40 years, and this should be an eye-opening time to revisit all of that, not just what's going on with COVID.
Well, Athena, I want to thank you very much for today's session. It was great. I want to thank all of the participants who signed on. It was great to see so many of you here and participating, and I'm sorry we couldn't get to all of your questions. But thank you for coming, and everybody stay safe and be well. We'll see you next time.